following along. I am Sue Kitchen for CNC at Charlie's Osborne Park, as you know. This is being recorded and it will be put on the North Metro YouTube playlist channel. So if you have your cameras on at the moment, you might want to turn them off so that your video isn't actually on the internet. The recording will be available in 2 weeks, and can you put your questions in the chat, or I'll open up the mics at the end anyway, so we can talk then. And if you want a copy of the presentation and any of the resources, just drop me an email and I will send them out to you. No point trying to reinvent too many wheels. Let's each share what we have. Okay, so it's only 40 minutes, so it's a bit of a whistle-stop tour of this. The aim is just to provide you with updated and practical information and resources that you can use as a health professional when you're implementing huddles. The huddles can be included as a requirement for several standards, ACHS standards, and they include the governance, partnering with consumers, comprehensive care, communicating for safety, and also clinical deterioration. And I have heard that the accreditors appear to like it when huddles are undertaken. There is such a thing as safety huddles, and these are huddles that are undertaken regularly that look at all different aspects of safety. So this might be a medication error that's occurred, or it might be a manual handling issue that you might have with a particular patient. It could be a pressure injury, could be anything at all. So you can use, once you've got the structure of huddles, you can use it to address any type of safety or adverse event on your ward. It's becoming more common in literature, but I'm not absolutely certain about widespread practice of this. The evidence is fairly poor quality, and there's certainly not very much of it from the last couple of years, which I'm assuming is pandemic related, and there is not conclusive as to whether it reduces falls. What is very important about them is that you think outside the box, that you're creative, that you're honest with each other, and that you are able to have a voice within the huddle. Don't rehash old stuff that doesn't work or should already be in practice. You want to have a very direct conversation and pointed conversation. So what is a huddle? It's a professional dialogue that focuses on the event. I guess essentially it's a mini and very rapid preliminary investigation. So what happened? Why did it happen? It's designed to identify those contributing factors to falls or to whatever event it is that you are talking about. If you're going for pre-fall, then you need to find out what the potential contributing factors to a patient fall is going to be. You identify and implement risk mitigation strategies and interventions, and they are very much designed to challenge assumptions. So don't assume. Speak up, speak out, challenge your colleagues as well, because that is what these huddles are designed to do. It allows a framework for a very critical reflection and analysis. So, really delving in deep, but very quickly, and makes working in a partnership with family and patients and the whole team very easy. It's very easy to achieve this solid partnership. There's many questions to consider to achieve success with huddles, and that it's actually quite difficult to achieve success. It takes a lot of hard work. It's not something you just rock up and say, hey, I'm going to do this today. It does need a bit of care and consideration and thought prior to it. It is very essential that you stick to the purpose of the huddle, whatever it is that you are talking about. So if we're talking about falls or pre-fall, you stick to that topic. Don't tangentialize, don't go off topic. What happened? Who needs to be included in the huddle? So this, I'll go into suggestions in a little while, but you do need to think about who needs to be there, who is important, who is would be nice if they were there, or don't really need them, but they may have something to offer. When are you going to hold the huddle? Now that's going to depend entirely on the ward or the area that you are in and where to hold the huddle as well. Who's going to be the lead? And that lead should change each time so that everybody gets a chance to be a leader and to learn the leadership role. What framework are you going to use? And I'll go into some of those a bit later. So you'll design your own. Once you've had a look at all different examples, you'll essentially, I'm quite sure, go and design your own that fits the specialty of the ward. What documentation are you going to use? How are you going to document? What are going to be the roles of the participants? So you're going to have the lead, you're going to have the scribe, you're going to need somebody to follow up that the interventions were completed, etc. And how are you going to manage behaviour of the lead and of the participants? And again, I'll touch on that in a little while. One of the big questions is, should the patient and the family be involved? And only you will know for that question. People who are cognitively impaired, I would suggest that they are not involved, but their family may wish to be. It's going to be your choice and the patient's choice at the end of the day. You do need to look at what training might be required and also further define the responsibilities of the participants. Perhaps it is that you use a sticker, so lead, scribe, follow up, so everybody knows what role the other person is playing within the team. Who do you consider including? So really the essential people are somebody from the medical team, nursing. Now that could be any or all of the above. So the primary nurse, the nurse that's looking after the patient right now, the CNS or CNM of the area, the shift coordinator. You might invite nursing specialists as well to come in. You'll need your OT and your physio and your pharmacist. They're your core group of people that you definitely need. After that, you need to start looking at who else needs to be included. So it might be the dietitian. So is there a possibility that this patient has nutritional problems? Are they malnourished? So, okay, let's bring the dietitian in. They might be able to offer something. The patient, obviously, and others. This might be the ward clerk. So the ward clerk, often their desk is often in front of rooms where we put the high-risk falls patients, and they are inadvertently watching these patients. They don't realise that they are, but I'm quite sure that they are. So it might be that you want to bring them in if the falls occurred, and they might have some ideas or some thoughts. Might be a security guard. It could be anybody. And that's what I mean by thinking outside of the box. Everybody is in the team. Everybody is included. If a huddle is conducted with a patient, you need to be very careful, very mindful of it, because a patient will think that they're in trouble. So you need to handle it really well. And they might be quite anxious. They might be quite concerned that, it might affect their care, which it won't, of course, negatively, and so you do need to handle the patient well and the family. Consent is so important. So explain to one person who's going to be the leader, goes in, talks to the patient, explains the process, and asks if they would like to take part. They don't have to, that you will come back and talk to them and share the information and discuss it with them. They don't have to take part. And would they like their family present? Please ask the patient when their family is not there, so the patient doesn't feel obliged to include his family or his caregivers. So it's a delicate process. It doesn't seem it, but it is a delicate process. And be careful not to overwhelm the patient or the family. Think about how you would like to be treated in this scenario. Get someone, if you are going in with a patient, get some members of the huddle to sit down. So, you know, those big ward rounds where everybody stands around the patient's bed, you know, looking down at them. And it's not a nice situation to be in, particularly when you're talking about a fall that the patient has had, that they're all already probably feeling very guilty about, and feeling that they've made so much work for everybody and that it's all their fault. You know, there's potential that they are thinking this. So I would advise, and I know from previous experience, that get some members of the huddle to sit down. It creates a much better atmosphere. Make sure that the patient can hear and explain the whole process again. Include the patient, ask their opinion. Can they describe the fall? Discuss the interventions with the patient. Do they have any thoughts on what they think? Don't use jargon. You'll lose them completely, and they're supposed to be fully engaged in this conversation. Always thank the patient and always go back and explain. So, you know, give it 10, 15 minutes for it to sink in a bit, and then go back and ask the patient, do they have any other questions? Do they understand what's happened? And how can they, what other information do they need? There is something called TeachBack, which I recommend you Google and have a look at. It is recommended as patient education process in falls. It's recommended by the World Guidelines. And essentially you ask the patient, what do they remember? And you keep making sure that they've got the correct information with simple steps. So use TeachBack. Now, these are a framework or a checklist. So this one is this is actually from Osborne Park, so acknowledge Osborne Park here. And this is the framework that they have developed. And you can see it there. It talks about risk factors, what patient staff were doing at the time, what are the underlying root causes, and what interventions need to be implemented. Let's talk about some more resources. So these checklists, you need checklists, and they form a framework. They're very helpful, and you can begin with one that's already available and then create your own that fits your specialty or your area. It is not going to be one size fits all. There are so many that are available in the literature, and I've got lots of examples, which I'm happy to share. So these are some of the some examples, and they can be written in. So this one you can write in this lessons learned and interventions that you find, and you can actually use that as a documentation. This one just asks the questions. So these are the questions that you need to ask during the huddle. And this one is a tick list. We all like tick lists. Sometimes that's very helpful and a very quick way of developing a huddle. And again, we have the framework there from Osborne Park, which actually I think is quite good. Documentation, so the huddles must be documented in patient notes, who was present and the discipline, contributing factors if any are found, the allocated interventions, so what interventions and risk mitigation strategies are you going to put in place, and who has that been allocated to? Is there a time frame? And then who's going to follow up, the follow-up and the date, because you need to make sure that those interventions are implemented. And these two here are just examples of documentation. They are stickers that just go in the patient's notes and are very easy to quickly complete as you're going through the huddle. So what's a good huddle? As many as possible turn up. as many as has been requested or invited to attend the huddle, that they actually are able to turn up. It's going to be very, very difficult to get everybody together. And those of you who are already doing huddles will know exactly what I mean. And you do need to find the time in the day that really helps. Huddles shouldn't last longer than 7 minutes. Each participant knows and understands their role. Should be held in a quiet area of the ward, so it really shouldn't be held somewhere where it's very distracting, where people can come and disturb the discussion, because that will prolong it, and concentration is disturbed. The patient and the staff in particular, must be engaged in the process, and they must be engaged in the discussion. And this is where the leadership comes in. You have to have great leadership. You don't want somebody in the huddle who is not talking. So the leader must make sure that everybody is able to voice their ideas, their thoughts, their opinions, whatever it might be. And great leadership will facilitate all of that. Don't go off topic, don't tangentialize, bring it back to the focus. Identify those interventions to reduce the risk of falls, whether it's a pre-fall or an actual fall, and everybody needs to follow through with their allocated tasks. You do what you can. When I say as many as possible turn up to the huddle, you do what you can. So the minimum really is nursing, physio and OT, and preferably medical, and pharmacy. And this can still be held over a secure link video. So if you're out in wax or rural and remote and it's difficult, it could still be completed. Find your routine, and it's going to be individual to every single ward. There's lots and lots of different resources that are available. The WA post-fall guidelines, so there is an appendix there for post-fall huddles with resources and information. The new post-fall guidelines, the 2023 version, hopefully, fingers crossed, will be out within the next 4 to 6 weeks. And again, that's got information in there. All of these are links to other different resources and tools and information and PowerPoints and videos, etc., that will be useful and give you more information. I'm going to show you the New South Wales ones later, but I really do recommend the New South Wales website. They've got everything. And why reinvent the wheel? It's all there. Certainly for Charlie's, we have adapted a lot of that material for use. And there is on YouTube, there are demonstrations about a good huddle and a bad huddle. Important to know the difference, and also what a safety huddle is as well. So go and have a look at all of those resources. So this is from New South Wales. So they have leaflets. This is about safety huddles, a post-event, and this could be a patient fall, but medication error, patient complaint, pressure injury, whatever it might be. But it has a leaflet which tells you and lays out exactly what it is that you need to do. They have one for post-fall huddle as well. So this is would inform all of your staff of what a huddle is, what the benefits are, and what you need to be doing, the process. Finally, they have a whole implementation guide. It's just heaven on a plate, really. So you can just go there and have a look. It explains how to implement huddles, gives you the materials, and certainly gives you something to work with and to adapt to your environment. I really like this particular flyer because you can see, hopefully you can see, that it talks about how to sustain safety huddles, and that's how do you sustain pre or post-fall huddles. One or two are all right. How do you embed it into practice? How do you sustain it? How do you get everybody on board? And this very simple flyer really gives you that excellent framework for introduction and implementation. you do need training, because this is not something that you just rock up and say, oh, we're going to do this today. You need to think about it a little bit more carefully if you're going to embed it. And you need to look at training. So when are you going to do the training? Who should deliver the training? What resources do you need for this? What's the venue? What training materials are you going to need? There's lots of videos, there's team sessions, you might need posters, you might need a workshop. It's going to be entirely up to you as to how you feel that the training needs to occur in your area. So the good and the bad. It's important to remember that not everybody is tough, not everybody is resilient, and some people, some staff members need a lot more care perhaps than others. I don't know, but needs to be considered. So some of the pitfalls are the risk of blame, on inadvertently showing blame. So let's say the nurse left the patient alone in the toilet for a reason. There might have been another patient calling, they needed to do medication, whatever the reason might be, and the patient fell. Sometimes it can be quite easy to say, well, they shouldn't have left the patient. And that there could be a showing, an inadvertent showing of that with body language, and that's not what we want. Nobody is to blame in this scenario at all, and that has to be emphasized, and has to be emphasized by the lead. People often feel very responsible and guilty if a patient falls on their watch, and they will have reflected, and they will have beaten themselves up about it. And so, coming into a huddle that is talking about this very scenario really can cause potentially a lot of fear, a lot of intimidation. So these are the pitfalls, and it is how the lead and the rest of the team handle the huddle that will help to support everybody through this. The patient might be distressed, the family might be distressed from poor facilitation. So if you happen to have a huddle where there might be a little bit of robust discussion, that's not appropriate in front of patients. They don't understand, and they could get distressed. It has to be a wally, professional discussion. You can get disinterest from health professionals. They're not interested. They feel that they communicate well anyway, and that these are just not required. And they will show that disinterest in a huddle, and that can be quite difficult to deal with. And again, this comes down to how your leader manages the behaviour. People not being interactive, and that might be because there's one person that has an awful lot to say and is not letting anybody else say anything, or they might be not feel able to speak up. Again, it's the lead that needs to make sure everybody has a voice. The positives of this that come up through research and are shown time and time again, and in my conversations with people who take part in huddles, this is very evident, that they love the teamwork. They feel part of the team. They feel that there is an increased collaboration and an increased cohesiveness by having these discussions. And this comes up time and time again in the research. Patient and family can be satisfied, but there's not a lot of evidence about that. So that's anecdotal. I know from patients that I've dealt with, and most of them are very, very happy and glad to be partnered in their care. A possible reduction in falls, we'll talk about that in a bit, but it's really the falls don't reduce. And how do you measure that? How do you measure that? Very difficult to measure. So I wouldn't advise that looking at a key indicator of its success as being a reduction in falls. Yes, look at it, but I wouldn't make it your main key indicator. Identifying the problem areas and mitigating. And the more that you do the huddles, it might be, let's just say you've done 4 in a row, and somebody will say, well, all 4 of these have happened all in the same bathroom. Has anybody noticed that? Oh, no, right, okay. So from that discussion, there might be commonalities that come out that haven't been identified previously. Increased knowledge of falls risk interventions, that definitely does occur, and improve practice. Barriers, the lack of enthusiastic leadership. You really do need your leaders in the ward and in the facilities to be enthusiastic and supportive. The culture of the ward is very important. Every ward has its own culture and everybody needs to be on board. Willingness of staff to engage and the willingness to work and practice change. Isn't that so difficult? That really is difficult. So we have, I'm going to say we have our routines, and yet they fill the whole day, the whole shift. Doesn't matter who we are, they fill the whole day. And then finding 7 minutes to go somewhere else and to introduce something else into your practice, no matter how much you believe in it, can be very, very difficult. And so working towards that can be challenging. And accommodating it into a general ward routine and finding out what is best. The evidence. It's generally low quality. I've been doing these presentations for a few years now, probably 5, 6 years, and it's generally low quality. Apart from one article being unable to find out where follow-up occurs after 12 or 24 months. So are these huddles still in place? Are they still working? Are they still achieving the outcome? Are they being reviewed? Is the process being regularly reviewed? The research itself does not commit itself. So it will say may reduce falls, required more rigorous research, or it was implemented as part of 27 interventions that were implemented all at the same time, so we can't tell what worked and what didn't. But the design and the makeup of the team and the leadership is crucial, and that does come through in the research. This was a systematic review, and looking at the impact of multidisciplinary teams, huddles on patient safety. So not specifically about falls, but patient safety. And you can see from what I have highlighted is that while anecdotal accounts of successful huddle programs abound, which they do, you only have to talk to somebody from a hospital that does huddles and they will tell you how fantastic they are. But with no evidence of, well, what evidence do you use of success? But the evidence in this particular systematic review appears favourable, and additional rigorous research, especially focused on huddle program design and implementation, is required. This one looked at leader behaviour in post-fall huddles, and it looked at an assessment of post-fall huddle experiences. And the huddles were perceived effective if there was appropriate leader behaviour and if the organisation had a safety framework that worked along with the huddle framework. So important to be looking at what's happening with your facility in terms of their safety framework. Could you make that work with when you start to develop your huddle framework? This one was in America, which I know has a completely different health system. But this was actually a 2-year project, and this is rare. 2 years, this is rare. So rural hospitals, 16 of them, they had post-fall huddles were introduced, and they looked at repeat falls rates. It did not reduce the repeat falls. but it did increase positive staff perception of teamwork for force risk reduction and safety. So as I was saying earlier, staff like it. They feel that it brings the team together to be able to discuss the patient like this. Patients, well, there's not a lot out there to say what patients think about these processes. Very minimal evidence, bit of a gap there. But it is certainly an excellent method of partnering. It is not for every patient, definitely not. But it's certainly something that should be considered. So the facilities that I'm aware of that are completing pre and post huddles in some way are Osborne Park Hospital. I know definitely that they have been doing pre and post. Charlie's, Fiona Stanley, Geraldton, some other WACS hospitals, and Glengarry. There's many others that I haven't mentioned. Please let me know if you are, so that I can add you to the list. Anyone who wants to contact the above areas, drop me an email and I'll put you in touch. Remember that these can be used in residential care. They can be used in the community. They can be used in all areas. Huddles aren't just about hospitals. Yeah, they can be used anywhere. So the take home for me is that the process really is the same, whether it's for pre or post form huddle, doesn't matter. It's very much dependent on the facility and the area and the specialty specific, and you may need to adapt your materials that you use according to your specialty. It is advised that there is a consistent time and location, and that does come through in the research. You have a core team, but that doesn't stop huddles being done. So at the weekend, if there's no physios or OTs available at the weekend, that doesn't mean that you can't do a huddle. So, you know, the nurse staff can get the medical staff together and we can do a quick huddle and then communicate this and talk to the OT and the physio as soon as they come in the next time. Maximum of 7 minutes, really don't make it long, it can't be long. And you're advised to stand, don't sit, don't get too comfortable unless you're in a patient's room. You must have a chosen and effective leader and advise that the leadership swaps around so everybody gets a chance to have a go. Choose the find the risk mitigation strategies, so the interventions that you need, and make sure those interventions are assigned to somebody so that is their specific job. It's just not left open. So this could be we need to check the roll on the foot, so we might give that to a physio or we might give that to a podiatrist, and then that action is allocated to them. You follow a framework. It's easier, certainly in the beginning, and training is absolutely imperative. If you're going to get people on board, it's really important. And you must review the process. So don't get comfortable, is my advice. Bring an outsider in, bring somebody else in to review the process, look at it, and offer constructive criticism, perhaps, on different methods or what they felt could be improved. I am very, very happy to share everything that I have done frequently in the past when people have asked me. So if you do want my toolbox, then please email me and keep checking the WA post-fall guidelines, because that will give you a lot of information. Right, I'm just going to stop the recording and then we'll open it up to questions.